Thank you all very much for coming. Good morning again. I'm Dr. Clifford Deal, President of the Medical Society of Virginia. Thank you all for joining our last webinar. Before we start, I'd like to remind everyone that MSD and its staff will continue to work diligently to update our website with relevant sources of information related to COVID-19 at msd.org/COVID-19. All of our webinars are recorded and posted to the MSD website. Again, msd.org/COVID-webinars. A couple updates. The webinar has been updated, and this is a CME event, and so I have to read the CME blurb. No commercial support was received for this activity. There are no reported conflicts of interest for any individual in position to control the content of this program or speakers representing the program. We are recording attendance and will submit to BCU for CME credit following the webinar. BCU will issue a certificate to you at the email that you get. Lastly, please remember to use the chat function. This has seemed to work pretty well. To ask questions while our speakers are presenting, we ask that you keep the questions focused on the topics being shared. And if we don't get to your questions, please email those to governmentafairs@msd.org. We will begin this morning with a presentation from Dr. Walker-Harris from the Governor's Office, followed by we're going to change the order around a little bit, Dr. Bromley, and then Dr. Peake and Dr. Jaberi, all from the Department of Health. After all the public health officials speak, there will be a brief question and answer. Then we'll shift gears and hear from OneDigital Health Benefits, our work compliance HR experts on how to transition staff to a new normal post-COVID-19. Joining us first today is Dr. Vanessa Walker-Harris. Thank you very much, Deputy Secretary of Health and Human Services, to give us an update on elective procedures. Dr. Harris, Dr. Walker-Harris?
Yes, good morning. Thanks again, Dr. Deal and MSD, for the opportunity to be with you this morning. I wanted to provide an update on resuming non-urgent procedures. During the last time I was here with you all, I spoke a bit about Order of Public Health Emergency 2, which prohibited non-urgent procedures and surgery, and that expired last night at 11:59, and folks are thinking through how they might safely resume non-urgent procedures, and wanted to talk through that a bit. So next slide. So just going to review what was prohibited and then kind of talk through some of the thoughts that we considered in the administration and the guidance that we have available on VDH's website related to resuming non-urgent procedures and surgery. Next slide. So as you recall, on March 25th, the governor issued Order of Public Emergency 2, and that was largely keeping in mind the fact we needed to conserve at that time personal protective equipment. And so we prohibited non-urgent procedures, and I won't walk through all of that since the focus is on moving forward at this point. But next slide. And as we're now considering next steps for reopening and resuming non-urgent procedures, what we really referred to primarily was national guidelines and guidance from folks like the Joint Statement Roadmap for Resuming Surgeries after COVID pandemic, from the American College of Surgeons, Association of Hospitals, the anesthesiologists, and perioperative registered nurses. And then there were a couple of other frameworks from surgeons in Washington State and others, and that's what we used as guiding documents to establish some general factors for folks to consider as they think through if it's appropriate for them to reopen and resume non-urgent procedures. And so there's an FAQ now available on VDH's main coronavirus webpage under their situational summary, and I have the website available in a forthcoming slide, but I'll walk through a few of the considerations. And so one of them is making sure that you're able to perform procedures according to commonly accepted standards of clinical practice, that you're not operating in crisis standards of care, and that if you're going to resume non-urgent procedures and surgeries, that doing so won't deplete your facility or your hospital's capacity of being able to respond to a surge of COVID patients, and it won't deplete your supply of PPE. And then another thing to keep in mind is that you'll have adequate staffing and supplies throughout the patient's course of care. So that's for the pre-op period, the immediate pre-op period, the intra-op period, and then everything that comes after that. So the PACU and then discharge as well. And then some additional feedback that we received is really thinking even before you decide to proceed with surgery, if the patient's going to need skilled nursing or rehab, and if that's available in your area, and how that might impact your surgical planning even before you decide to proceed with surgery. And that at each step, you're ensuring that that decision-making won't detract from any local surge needs. And then another consideration is that we've asked hospitals to think through how they can resume non-urgent or medically necessary time-sensitive procedures in a manner that would conserve 25% of their hospital capacity. And when we think through hospital capacity, that means the beds, the ventilators, the staff, the supplies to take care of COVID patients. We know that a number of hospital systems have done a great job using the expanded opportunities through Executive Order 52 to expand their licensed beds, to bring on additional capacity to surge. And so we appreciate everyone's efforts in that regard. But as they think through resuming medically necessary time-sensitive procedures, want to be sure that they're continuing to reserve capacity to respond to a surge in needs for COVID. Next slide. And then again, back to PPE. We don't want to, run out as we're resuming procedures, and so want to maintain adequate supply. And one objective measure of that would be to maintain a 30-day supply so that you have sufficient for universal precautions and enough for the procedures that you'll be undertaking. And then to be able to adhere to CDC guidelines for environmental safety so that you can make sure that all the health system personnel and patients are wearing masks, you're appropriately limiting visitation, and then promoting the use of telehealth as an alternative to face-to-face visits where that's available and appropriate. And then also testing as appropriate as we're resuming, and that this was emphasized across most all of the frameworks that we referred to, that each facility and site needs to have a preoperative testing policy developed and implemented, and then ensuring sufficient testing capacity so that you're able to appropriately implement that testing policy. And really thinking through how health systems might help outpatient providers to connect with appropriate testing and work together so that you're able to perform the diagnostic COVID testing that adheres to your preoperative testing policy. Next slide. And then we know that throughout the course of the COVID response, clinicians and facilities have been tracking pharmaceutical shortages, the same as what you've done in routine times, but particularly the drugs that have been used for respiratory care and for anesthesia have been very closely monitored. And so ensuring there's sufficient supply of those medications before you decide to resume these non-urgent procedures is of critical importance. Keeping an eye towards global drug shortages, which we know currently exist and may increase as demand increases, and then having a plan to mitigate those shortages will be particularly important. And then lastly, establishing an objective method to prioritize non-urgent surgeries. We know that folks have been very judicious and really exercising great clinical judgment in what procedures to move forward with during the time when the order of public health emergency 2 was in place, and now needing to go through those lists of procedures that have been postponed and prioritize them to get patients appropriately cared for. And establishing a very clear and objective process to continue prioritizing procedures as the response moves forward. The joint statement, as I mentioned previously, has a really good framework for thinking through that and recommends facility level committees and the MENTS medically necessary time-sensitive framework and references University of Chicago study as a potential way to approach prioritizing urgent, non-urgent procedures moving forward. But I know there are a number of folks on the webinar who don't do procedures or surgeries, but are also getting back into their offices and reopening. And so we do have suggestions for resources if that's your particular situation. Thankfully, a number of the national professional societies have terrific guidance, so we advise referencing those: the American Academy of Pediatrics, the American College of Physicians, the American Academy of Family Physicians, the American Dental Association, all have quite excellent guidance. The American Dental Association has a toolkit for resuming work, and locally, the Virginia Dental Association pushed out a toolkit to their membership to aid them in resuming practice. Next slide, please. And then lastly, here's where the FAQ is located on the VDH website for resuming non-urgent procedures. It has a bit more information about PPE, and Dr. Jaberi will be highlighting that as well in his remarks coming up. And next slide. If you have additional questions, you're more than welcome to ask at the end, but here's how you can reach me. We're happy to receive feedback as folks start resuming their work and have experiences that you'd like to let us know about. We're happy to understand what your experience is so that we can provide information that might be helpful and fine-tune our FAQs and receive information from you so that what we push out is most helpful to you all. Thank you.
Dr. Harris, Dr. Walker-Harris, thank you very, very much. We're going to change up the order a little bit and go to Dr. Karen Bromley first, and then we'll go to Dr. Lillian Peak and Dr. Jaberi. Dr. Bromley?
Thank you. Good morning, everybody. And I'm sure many of you are very excited to start to kind of get your old life back in terms of taking care of patients and being able to do the procedures and surgeries they need. I know my husband walked out the door with a little bounce in his step today, and I'm sure many of you will too. I don't have any slides. I just wanted to briefly share, and I know Drs. Peake and Jaberi will go into more details about how we're looking at surveillance and testing. But wanted to say that we have at the DGS website, it's linked through at VDH right now, and we'll get you that information. If you're looking for open channels to be able to get more personal protective equipment, the Department of General Services at the state has vetted all of these, has a list of who has open channels, who is also not doing price gouging, and so it can be a reliable place to go look at that information. We hope by next week to have the same thing available for testing labs. In talking with both Quest and LabCorp, who a lot of you use, they have a 48 to 72 hour turnaround time now with less than 24 hours for hospitalized patients. And are comfortable that unless there's a major surge somewhere else in the country, they can meet that need. I think Dr. Peake is going to talk more about the fact that the requirements for obtaining the test have been significantly changed. Will it be much more compatible and conducive to doing in your offices? And I will let her walk through that. We are also putting together a team by next week that we could essentially consult with your nurses or your lab tech over the phone to walk them through how to do that if they want more additional knowledge. I've worked with Chris Bailey at the VHHA because I received a number of phone calls from people and email yesterday from many MSB members saying that there are different pre-op testing or pre-procedure testing guidance from different hospitals. He is going to work with the chief medical officers of the various systems to see if we can better align those. For those of you that work in multiple different hospitals, it can be very difficult if your staff is trying to figure out what to do where, and we want to do what we think is best practices, because there has not been, consistent guidance from the CDC for that yet. And lastly, I'm also going to be communicating with the health plans. A number of hospitals and a number of specialties have pay for performance, quality improvement programs that they've taken part in, just reassuring that physicians won't be penalized for not having to be part of that, but also thinking about as you're participating in COVID testing or getting it, you know, it doesn't have to be done in your office, but you have a channel to get it and it's happening, is that something that they could look at? I encourage all of you to really think about how you either can test in your own office, but if you feel that that's not going to be something you're going to be doing very often, that you work with your health system to identify a way to test people quickly and efficiently. In most of the time, sending them to urgent care centers as we make this bridge to normalize the testing will not be as effective because they're going to be paying a much bigger charge for a visit there. If you have areas in the state that you feel you don't have access to testing, please email me or Cliff and let us know. And then lastly, I don't know if Dr. Jaberi or Peake are going to show you this slide, but it went live a few days ago, which are public testing sites that are available throughout the state. We've gone from 100 to 160 in 3 days. If you would like your office or urgent care center on that list to be available as a public testing site, please let us know and we will add you to that list. It allows a patient or a provider to put in a zip code and to see what are the closest public testing sites available. And I will stop there, Cliff. Thank you.
Karen, that's awesome. It's a tremendous update for everybody across the state. Thank you all very much. So next we're going to go to Dr. Lillian Peak. Dr. Peak?
Good morning, everyone. It's nice to be back with you again today. I'm going to give just a really quick update on epidemiology and some more information to add on to what Dr. Bromley said about testing. So as of yesterday, we had 15,840 cases of COVID in Virginia. And at the time of investigation, we identified 2,322 hospitalizations. As I explained last week, that is an underrepresentation because people become hospitalized later in their course of illness. And then we've had 552 deaths reported. That's also an underrepresentation, and we have now started a process where we're going to be regularly reviewing vital records to identify other cases that aren't reported. And so you'll see that number increase a little bit in the near future, and then we'll have a regular tracking system in place for that. Next slide, please. So I showed you this last week, so just a very quick reminder that COVID can affect people of all ages, but when we look at the severity of illness, we really see the severity and the deaths increasing with increasing age. Next slide, please. And this is just a breakdown again. We're still hoping to have increased reporting of race and ethnicity in Virginia. It's really critical when you submit a lab slip that it does include that information if possible so that we can track that better. But you can see just a breakdown of the cases compared to deaths by race, ethnicity, and then sex in Virginia. So we're still responding and tracking outbreaks. So far, there's been 224 outbreaks in Virginia associated with COVID, and we are now tracking the cases in healthcare workers. This again is underreported. This information is not collected on all of the cases, but we are trying to track that and so at least we can look at the trends. So for the outbreaks, we're still seeing more than half in long-term care facilities, and the chart on the bottom just shows you the cases and deaths associated with the different types of facilities. So again, as we discussed last week, long-term care facilities really pose significant risk with the poor outcomes with COVID. Next slide, please. I just want to talk a little bit about testing going forward. Next slide, please. So this is a busy slide, but I think it does a good job of laying out the different types of interventions that are needed during an epidemic. And so if you look at the top line, that's a representation of an epidemic curve. And it's not a specific one, it's just in general what you would expect to happen with the epidemic curve as time goes on. So first, you have the virus is introduced into the population, and so it takes a while to begin to spread. And then it gets to the point where you start to have exponential spread, and that's where you can see the line sharply increasing, and then it begins to decrease over time, and then you can expect to have subsequent waves in the future. So because of the social distancing that we've put into place, we have really changed the trajectory of that sharp curve. So you can, we haven't had that sharp incline. And so if you look below that representation of the curve, you can see the different interventions. So for disease control, that's really public health. We're looking at early detection. That's your job. Identify those patients early. And then there's the need for testing with a new virus like this, so we really understand what's going on. And then contact tracing, of course, healthcare infection and prevention and control, and appropriate clinical care. So you can see that there's a break in the line for testing and contact tracing, and that corresponds with the peak of the epidemic. So at some point, it's not, you don't necessarily have to test every single patient. If we have a shortage of tests, or we really understand what's going on, and at some point, if the risk is very broad in the community, and you don't have the staffing to do as much contact tracing, there is a break in those processes as well. But the purple lines show you the non-pharmaceutical interventions, and a way to consider this is we've been able to not do as much testing and contact tracing, but the cost for that was all of the non-pharmaceutical interventions. And so as we want to get away from these non-pharmaceutical interventions to some extent because of the effect on the economy and just, the effects of being isolated, we have to be able to ramp up the other side. And so we really do need to look at how we get more diagnosis, testing, isolation, and quarantine of cases and contacts. So next slide, please. So the way to look at this from the public health side is that we'd like to see patients tested widely, cases reported to the local health department. We then work with the people to make sure that they are staying isolated while they're infectious. And then we work with them to identify people who they could have been in contact with. And then we test and work with those people to hope to quarantine them if testing isn't available, or test a sort of a combination of testing and quarantine as we have more testing available, so that people don't have to go through multiple rounds of quarantine if we can avoid that. Next slide, please. So this is part of the governor's plan to begin to reopen the economy and the community, and the metrics that are being followed in Virginia are, we want to see a downward movement of the percent of positive tests over 14 days, and then a decrease in hospitalizations over 14 days. And then we need to make sure there are enough hospital beds and intensive care capacity to be able to respond to a surge in cases, which we will definitely see, and then an increasing and sustainable supply of PPE. So I think we talked about this last time, but that percent positive test, what we're really looking at there is it's not really a proxy for prevalence. It's really getting at, are we testing enough people so that we don't have a lot of people who have the disease that haven't been identified in the community and are spreading it unknowingly. So next slide, please. Just looking at the tests over the last 7 days in Virginia, you can see that that the average was 3,761 with a mean of just over 3,900. I'm happy to see the new report this morning, and there were 5,808 tests reported yesterday. So we definitely are increasing, and we want to continue that trajectory. Next slide, please. So this is getting back to the percent positivity by day. So the light blue lines or bars are the total tests by day in Virginia. And then the dark blue lines are the total cases in Virginia. And then the yellow line is the percent positivity, which is shown as a 7-day moving average. So you can see that it had been increasing significantly as we had increased testing, but that is now starting to decrease some while the testing is continuing to go up. So that's good news. We're testing more people, we're testing a more variety of people so that we can ensure that we are identifying cases early. Next slide, please. So Johns Hopkins University has begun to show a comparison of testing per population by state. And as I'm sure you've seen in the news, we're not faring very well in Virginia. So you can see by per population, this was as of April 29th, Virginia was testing 1,009 people per 100,000. And if you compare that to other states, Maryland was at 1,836, DC at 2,737, and at the top, Rhode Island testing 5,690. So we definitely have opportunity to increase that and to reach more people through testing. Next slide, please. So we've had, there's really 3 barriers that we've had to testing. First of all, there's been a barrier to getting the test equipment and reagents. There's also been a barrier to actually getting the collection kits, so both the swabs and the viral transport media. And then there's been barriers to getting adequate PPE. So we had a briefing with FEMA this week, and we'll have a one-on-one meeting with them with our state today. So we hope to get this nailed down and hope that this is going to pan out. But we're setting a goal to test at least 2% of the population in Virginia in the month of May. And so that would basically be, the more than we've tested thus far from the beginning. But that, if you translate that, just divide that by 31, that is 5,500 tests per day, and that's what we're doing now. So we need to keep on this trajectory and hopefully even increase that so we can begin to make up some of the ground. And then FEMA has said that they will be providing 100% of the swabs for that number of tests and also 75% of the viral transport medium. So we are hoping to receive that in Virginia, and we'll be looking at how to distribute that to the providers. Next slide, please. So to go along with this, the CDC has also changed its specimen collection guidance. And while an NP or OP swab or NP wash or nasal wash can still be collected by the healthcare professional, an alternative to that is self-collection by the patient, and that's just a nasal swab. So for providers who are handling the specimens but are not directly involved in collecting it, and then they're working 6 feet away from the patient, and they can just follow standard precautions, which are a lab coat or gown, gloves, and eye protection. So that really changes the situation for being able to diagnose and test some of these patients. If you're able to do phone triage or triage in a way that you can keep that distance and then the testing can be done in a way, then that's really a game changer. Next slide, please. So we are going to be changing the priorities for testing in Virginia. We'll be rolling this out today. So we're really looking at this in two different buckets. So the priorities for healthcare are hospitalized patients, and then the healthcare workers and first responders who have symptoms, and workers and residents with symptoms in congregate setting. But it is also a priority to test anybody who has symptoms of COVID. And as I shared last week, that's a much broader list now. It isn't just people who have fever, cough, or shortness of breath. And then also to look at screening people who are asymptomatic, to be able to look before procedures and as needed. So next slide, please. And so just to be clear, that really should be done with private testing. So we're really encouraging everyone to work with their healthcare systems and private labs. We have the large labs, but there are also a number of smaller labs that do provide tests. And so it takes a little more creativity to figure out how to work with them, but we should be looking at every possible resource in Virginia so that we can maximize the use of private testing. And then that allows us to begin to use the state lab for public health testing. And the priorities for public health, the high priority is outbreak investigations and selected contact investigations. And then it's also a priority to test people without symptoms through our public health monitoring program, like I described with quarantine. And then also sentinel surveillance, and that includes our point prevalence surveys that we're doing at nursing homes and other congregate settings. So we realize that we need to have a bit of a transition. It's hopefully, we can see by the testing numbers that it's already going into much higher testing, and we're excited about that, but we also realize that outpatient providers may still need a little bit of time to get all of these processes in place. And so as we want to make sure all of the lab capacity is being utilized in Virginia, so we want to help you and whatever we can do to support healthcare systems to conduct some testing clinics. These drive-through or walk-through clinics can really help us identify people that need to be diagnosed quickly so that we can start working with them on the containment side. And then as you increase the capacity, we'll also at the same time, though, be needing to build up our workforce for containment efforts. We will be hiring more people to assist us with contact tracing and looking at ways to expand our ability to do that. So we will be really busy on the public health side in May, and we hope that you will be too, to really be able to take over all of the testing for diagnostic purposes, so that after that transition, we can use all of the state testing to support public health surveillance and containment, and you're able to access testing through private labs. And I think, next slide, please. I think that's the last one. Okay, this is the website that Dr. Bromley referred to. So we do have a site, this portal on the VDH website where you can put in your zip code and it will show you where you can access testing. And so we want to make sure that people know where to get testing, and we hope to see more sites added to this. And as she said, we encourage you to provide your information so that we can make sure that people know where they can get tested. Next slide, please. Okay, thank you so much. I appreciate this opportunity to meet with you today.
Dr. Peake, thank you very, very much. That was a tremendous presentation. And again, those slides will be on the msv.org website later on this afternoon to be able to follow all those links. It's a terrific website about locating a testing center. So we'll go to Dr. Jaberi, and then we will go to the OneDigital for the MSV insurance agencies after a few questions from for the group, because there are a couple of things coming up on the chat. Dr. Jaberi?
Good morning. Thank you for having me again. Appreciate you. So I'll be pretty quick. My focus was to just put a few things together from the health coordination side. It's a pretty diverse group. And I've spoken with you all a little bit about what we do, and then focus on PPEs. So thank you for having me. This is just the organizational chart to put it all in perspective. You know, so much has happened over the course of the last month and a half, and definitely some positive news. When I was here last, I spoke a little bit about the subcommittees. If you look at the box that says Healthcare Coordination Team A, under there we had a number of folks that are working both from the private sector, the public sector, and many of our state governmental agencies in these various subcommittees. Some of the forward advancements that we had through the VDMAC, the Virginia Disaster Medical Advisory Committee, which Deputy Secretary Walker-Harris has been leading for the last few weeks, is that we moved the level of care in the state from regular conventional care to contingency care. And I'm going to speak about that in relation to some additional protections for liability that the governor issued through an executive order, realizing that we're not operating in exactly the same circumstances as we normally do. But the good news is we never really reached crisis standards of care. So as we talk about PPEs and other scarce resources, the goal is not to get there. We've realized that through social distancing, through public health measures, and as we increase testing and containment, we're able to prevent from going into crisis standards of care. Some of the other subcommittees, EMS, I'll provide a quick update about one of their new learnings, telehealth help through Dr. Karen Bromley out of UVA. Acute care and medical surge, that's what I focused on the last time I was here, talking about the build out of those large alternate care facilities at Dulles Expo, Richmond Convention Center, Hampton Roads Convention Center, and those things have been put on a pause, again, given the fact that we were able to control the spread of this illness through those non-pharmaceutical measures, and were quite successful, of course, at the expense of our economy. So as we go back and open up, we're going to be having a very close look at where those numbers are going for hospitalizations and making the appropriate adjustments. And our focus in medical surge is now more long-term care facilities, Department of Corrections, assisted living facilities where there's congregate living and high rate of spread. Long-term care, that's a task force in and of itself that Dr. Deal, perhaps Dr. Forlano and Deputy Secretary Berger can come and speak to this group, but just again, realizing that we have a really high case of morbidity and mortality in those centers. The governor created a task force to look at those specific issues. And while this subcommittee under mine was headed by DMAS and looking more at the 1135 waivers, the task force is even a larger group of folks, over 100 from various agencies, leading age, assisted living facilities, that is helping inform our direction and going forth. I'll provide a couple updates from pharmacy services in my slide, and mention that we've also formed a group under provider wellness, realizing that this particular event is really taking a toll on our frontline providers. We've seen the images out of New York, but we're beginning to see some of that as well in some of our acute care facilities and our long-term care facilities, and we just realized that we want to be getting ahead of that. You've heard in terms of testing capacity and coordination, this is turning into a task force, again, led by Dr. Peake and Dr. Bromley. Provider outreach and detailing, that's what we're all doing here together, making sure that we keep our providers informed and closely connected. Thank you, Dr. Deal, again to you, to Clark Barano, to Lauren Bates, for your continued assistance on the medical workforce, as that remains to be an issue, particularly in long-term care settings. Community mitigation is turning more into economic recovery. Dr. Peake discussed some of those measures that we'll be looking at to open up our communities once again, and then public health surveillance and guidance, of course, throughout the course of this event. That's going to be critical, and a lot of the work that, again, Dr. Peake's group is doing touches on that. So I'm going to focus on a couple activities here in healthcare coordination, and focus on PPEs here today with you. A couple of new updates for this week. Governor Northam announced on April 29th that Order of Public Health Emergency 2 will be allowed to expire at midnight. So Dr. Walker-Harris has already walked us through this. And one of the main considerations, again, that we didn't allow this order to expire last week was because of our uncertainties about PPE availability. So that's really been the cornerstone of why we pushed it back, and one of the most important considerations that I'll speak to in just a little bit again. In terms of hospital capacity, I'll show on the next slide in a second that we have that. The hospitals, as many of you know, the acute care facilities are at about 30 to 40% capacity. And obviously that's going to increase as we open up elective surgeries and may continue to see the spread of this illness in our communities. But really the main limiting factor was the PPE. And of course, we're in much better shape. And so Governor Northam felt comfortable this week to allow that order to expire. He also issued Executive Order 60, which enforces certain existing statutory liability protections for Virginia healthcare workers. Many of you know that in cases of disasters, there are certain protections that are offered to providers, and the governor wanted to ensure that those continue in this particular wide event. I mentioned we didn't get to crisis standards of care, but we're in contingency. So one example could be that we began considering if two patients needed to share a vent. We may not normally do that. We don't normally do that actually in everyday setting. But in the potential case where we run short and that provides the appropriate care, the sufficient care for patients, we consider that contingency. It's different from every day, but we're hoping that the outcome is the same. Crisis would be we're not going to have an event and we're going to have to make a tough decision about allocation of scarce resources, and that's not where we want to go. But certainly this was something very much supported by our provider community, and glad to see that it has come to fruition. Next slide, please. So Dr. Peake showed the dashboard that, we go back up one. Dr. Peake showed the dashboard for VDH. This is another one that we use in the command center at the state, and a couple additional lines. These are a couple days old, but in general, on the upper left-hand corner, you see hospitalization cases. And so we've got those that are testing positive, and looking at the total rates and the total discharge. In the middle column, we see the ventilators and ICU cases over time. So total vents on hand, you see a small increase in the beginning of April as we're able to put into repair some of the vents that may have been in disrepair, added additional capabilities. Part of this is through the Executive Order 52, which allowed some conversion of, for example, this is mostly due to new ventilators and ventilators that were in disrepair that were expanded. What I want to show is the blue line, total ventilators in use, obviously with the stay on elective surgeries and procedures. This is just for those who are critically ill that have continued to remain in the hospitals. And then we specifically point out those that are used for COVID care, which is about a third of them. So we have quite a bit of capacity between the blue and the green line. And so hence, with increased PPEs, with the continued increase in availability of ICU vents, the space, and obviously the staff still, we felt comfortable about supporting and recommending that Public Health Order 2 comes to a close last night, and we will monitor this delta over the next few weeks to see how we progress. And last but not least is what I'm going to talk a little bit more about today is the hospital that we're saying they had difficulty getting PPEs. And so we are beginning to see that really come down to just, I believe, one facility that was reporting difficulty in the last period in the last cycle. So again, what this shows is we have current capacity. We are doing much better with our PPEs. And we'll be monitoring that very carefully over the next couple of weeks. Next slide. Dr. Peake is really our expert. He's been working with our UVA partners when it comes to projections, but I wanted to show this. I think we presented parts of this slide a couple weeks ago showing that, again, the gray would have been the line had we not done anything when cases had come to Virginia. We would have seen an exponential growth, and that would have been the unmitigated circumstance. What we wound up seeing is that we were actually able to slow and potentially even look towards a slight pause, but it was really much more slowing, which is shown by the pink as a result of our extreme social distancing efforts. So it worked. We were able to truly bend the curve, and when we're seeing the results of that success, though again, the numbers are still continuing to go up, it is not at the exponential rate that we would have seen had we not taken those measures. And on the next slide, the impact of that really comes to be noticed is that if we not taken those measures, we would be looking at over thousands of cases a day here in our community. But we were able to successfully bend the curve. And so the question is going to be, if we go back to our normal daily lives and routines on June 10th, where and how quickly are the cases going to increase? So these are some model projections by UVA. The point here is that, again, we've decreased the peak, we've flattened out the curve, and one of the most important parts, obviously, from our perspective, is we want to make sure that we don't overwhelm our surge capacity. And so there may be opportunities to pulse this if we see our numbers going up, our hospitals becoming really full, the ICU vents becoming limited. We may once again invoke some additional restrictions, but at this point, we are optimistic that the course that we're following is one that we can, that has bought us some time. And again, we'll be monitoring very closely where we are headed in the days to come. But at this point, again, the peak of those cases in terms of where we may potentially overwhelm our hospital capacity, which again, I think is going to be something that we're going to watch very closely, but we pushed that back well from what would have happened now or in early May back into the late summer months. Next slide. So to reinforce some of the points that Dr. Walker-Harris spoke to us about, as we were lifting the ban on elective surgeries and procedures, realizing that PPE allocation is going to be something that we got to look really carefully at. As we also get more sources, we developed an advisory group. We had, this obviously operating through the Unified Command, VDH, Department of Emergency Management, a number of other partners. So we formed this group, and we're really helping inform the strategies. And this is how we believe it's going to work. So healthcare coalitions, which is our coalitions working hand in hand with the Virginia Hospital and Healthcare Association. So they get the funds from our hospital preparedness grant dollars and are really charged with coordinating their healthcare needs in an emergency. As has always been the case with H1N1 and others, they're the ones who receive the supplies and send it to our private or our hospitals, our acute care facilities, our nursing homes, our dialysis centers. Local health departments had been pretty much for anyone and everyone else. And so this included community providers, medical, dental, ancillary services, pharmacists. In this particular case, as we're beginning to see more and more PPE needs across sectors that normally don't request PPEs, including, at least from us, including court systems, all the first responders, we've also rolled in the local emergency management officials to help us with that effort. With the long-term care facilities being a really important part of what we're looking at in assisted living facilities, raising in prominence, not just looking at nursing homes, but also ALFs, Department of Social Services will be helping distribute those PPEs as they're the ones who license those facilities. And then, of course, another congregate setting is Department of Corrections and ensuring that the offender population there, and as many of you know, Department of Corrections, the larger state prisons, have large health clinics and long-term care facilities within Department of Corrections. So we want to make sure they have the appropriate PPEs as well. Next slide. Dr. Walker-Harris pointed this out, and this is from one of the FAQs that was developed in response to the lifting of the restrictions on elective surgeries and procedures, is that public health is going to ensure, and really needs to, until we continue to get additional supplies, of having PPEs ready and available for public health responses, outbreaks, testing, and working with COVID-19 positive patients. And so we really need the private sector, both at all levels, to ensure that they're using all their channels to get the PPE that they need. What we have done at the state is we've been flooded over the last month with multiple vendors offering their services, and as you all know, whether this or testing, we have had some unfortunate bad actors. And so the vendors that have been vetted by the state, we have posted it on websites, so individuals who perhaps would like to order some can go through and look at the list of vendors that, again, have been vetted, verified through 2 state websites here for your information. So again, this is to encourage private providers to go through and get the PPE they need and not rely on what is really available through state and federal caches, as those are going to be primarily reserved for direct COVID-19 response. Now, if you're doing COVID testing, if you are seeing COVID-19 patients are somehow involved in mass care or alternate care facilities, that becomes a different story. But for the day-to-day practice that is not really geared towards COVID care, we need our providers to go through these links or other sources to get that PPE, not through the local health departments. Next slide. This is the snapshot from what Dr. Stern, our emergency manager leader for the state, shared, modified the slide a little bit to that just simply removes some of the other statistics and figures, but I've kept most of the important things. And here's what we have, is that we have the gray basically shows what's been distributed, the lighter gray is what we have on hand. So we have a lot of gloves on hand, and then the blues are basically what we're expecting to see and are on the way over the course of the last week. So we're very confident that we're going to see a large surge in the number of N95s and KN95s as you see in the top line over the next couple weeks. Some surgical masks. We are fairly short on coveralls and gowns, but we're going to continue to try to identify those resources, and certainly millions of gloves on hand. At the bottom left, we are working and bringing in decontamination systems into the state. We're looking at bringing 3 of those. We realize that that is not always the number one way of going about care, again, thinking about contingency, but these are approved methods. We prefer to, of course, have new PPE and use them as you know, one per patient, but as times dictate, we have adjusted our abilities to ensure that our resources go as far as they can in terms of use and applicability in the clinical setting. We're continuing to work with our private vendors to bring more PPE into the state. And, you know, there's some conversations about folks out in the public. You know, we still want the public to wear masks, to wear protective gear. And some of our Department of Corrections partners will be helping with some of those things. So as we go forth, the advisory committee that I mentioned, we're looking at who else needs PPEs, folks in assisted living centers, child care, social services, those that are working on case management with COVID-19 patients. So it may again be those that we don't individually think of usually as the healthcare provider, but they're certainly very important and integral in reducing the risk of transmission and taking care of those who've already been diagnosed. We're going to continue to look at this measure, just like the hospital measures, the ICU capabilities, to help dictate kind of how much we can share with our providers out of the public caches and what we cannot. Right now, we have some discussions about funding sources. So last night was a late discussion with Deputy Secretary Walker-Harris, is that the funds currently used to purchase these these PPEs was dictated as PPEs for COVID care. So, you know, that'll be something we're going to continue to look at. If our providers out there are not able to provide clinical care for patients because they don't have PPEs, even if it's not COVID care, that may attribute to potential increased morbidity later on down the line. And of course, we don't want that as an unintended consequence. So we're going to have continuing conversations around this. I'll go on to the next slide, which I believe is the last one. And so it just simply takes a village. This is another slide again from Dr. Stern and the Virginia Emergency Support Team. Getting PPEs out is a combined effort through the Department of Health, Department of General Services, which has these warehouses, the National Guard that helps us distribute, emergency management that helps us procure these, and of course our private logistical chain. So it really does take a village. And with that slide, I'll end the presentation. Thank you.
Dr. Jaberi, thank you very much. Very comprehensive look at everything going on around the state, especially the organizational chart. Definitely lots of moving pieces. We've got lots of questions in the chat function that a lot of them relate to PPE to be seen in the office if you're seeing asymptomatic patients, and is COVID swab testing required before non-urgent procedures? But we need to get to before 9 o'clock, get to OneDigital. Dr. Jaberi, can you just answer maybe those 2 questions, which is the suggested PPE to see asymptomatic patients in the office?
Asymptomatic, the surgical masks will do.
Yep. And then what I read on the slide for pre-op testing for non-urgent procedures is to develop a policy, and didn't say what the policy was.
That's correct.
Go ahead.
So to Dr. Bromley's point, there is a lot of differing guidance about the pre-op testing, and she noted that she'll be working with BHHA to try to work towards some standardized guidance about pre-op testing policy.
All right, so that's about all of the questions. We will work to address frequently questions from the chat function on the webinar and to address those on the website later on this afternoon. But I would like to go to the MSD Insurance Agency's long-term strategic partner for HR support. Ann, I see you on, and Ritter.
Yep. Good morning.
All right. Thank you all very much.
Thank you very much, Dr. Deal and MSB for giving us an opportunity to come on this morning to speak with everybody. We'll keep it quick in light of time, but today we just wanted to discuss a few things and some thoughts around how to transition employees over to the new normal as we look to shift from response to recovery. So we'll cover briefly a practice recovery plan and an opportunity to maybe think a little bit more strategically and holistically than we have before. Ann will cover building your recovery HR strategy from the ground up. It's potentially an opportunity to rethink some of those things as well. And then we'll discuss an employer toolkit. I don't know that we'll have time for Q&A, but we could always answer questions after the fact. So next slide, please. So as we look to bring employees back to work in a very different environment, this may be an opportunity to think more strategically about how your practice and the business component is set up. So as the employee benefit partner for the Medical Society of Virginia, what we're doing is we're challenging clients to take a more holistic approach to kind of 4 key areas: benefits, human resources, employee experience, and also the financial well-being that we know, many of these employees were impacted potentially, financially as well. So that could be a concern. So as we're looking to challenge them to kind of, look at these things differently, they could improve the experience for not only the employees, but also control costs for the practice in a post-COVID environment. So just briefly, as we look through these, benefits, if you're looking at that, there could be ways to control costs there, look at doing things in a different way, potentially a different funding arrangement, self-funded versus fully insured, potentially increasing deductibles, but backfilling with other forms of insurance to lower costs for practices, for the cost of covering health insurance without passing on extra exposure to the employees. And then there's the human resource and employee experience components that Ann will talk about. But these are all major factors as we consider, because it's a very different environment that we're moving into. So with that, I'll pass it off to Ann.
Thank you, Ritter. Next slide. What we are showing here is a model of kind of a pyramid that looks at both tactical and strategic HR people operations. And what we know is as you are opening your doors, there are going to be a number of different things as leaders, as individuals managing an organization that your employees will respond to. We want you to think about if the foundation of compliance and the Family First and the CARES Act. Obviously, employee safety is an opportunity for you to be thinking about and thinking through your policies and practices. Many of you may have had to furlough or lay off individuals, and so there may be some rehiring and re-onboarding processes. And to benefits, as Ritter had described, there are certain options that you might want to consider. As you look a little higher on the model on this pyramid, thinking through mental health and wellness and leadership as it relates to both short and long-term planning. There's a series of communication issues that obviously are going to be required from you, as well as just good business practice. Next slide. We have a toolkit that is available to you in the COVID hub on the OneDigital website. You can see Ritter's email and contact information. We encourage you to go look through some of the information. There are tools, templates, toolkits, communication processes, policies, and a whole host of information. So we appreciate the opportunity to present to you and look forward to another point in time where we have a little more time.
Well, thank you all both, Ann and Ritter. That's a terrific overview. We'd like to get those slides and those hyperlinks onto our website for this afternoon. And thanks for putting your contact information on there. I know we're a little bit compressed for your all's part of this this morning. So we're right at 9 o'clock, and so we will try to address some more of the questions on our website this afternoon. But this will conclude this morning's MSV webinar. Thank you all very much for participating. We'll see you all again same time next week. Thank you.